And I would like to welcome everyone to our First Steps quarterly webinar. We are glad that you're all able to join us today. I am Shalia, for those of you who don't know, the program manager for First Steps Infant Case Management. And I will let Heather introduce herself.
Good morning, I'm Heather Wire, and I'm the program manager of the First Steps Maternity Support Services, MSS program, and the Childbirth Education program, and our Substance Using Pregnant People program. And this webinar is being recorded. So if you, we do keep the attendees on mute. So if you do ask to be unmuted, just please note that this is being recorded and your voice would be heard.
Again, at any time, if you have any questions during the webinar, you are able to put that in the Q&A box, and we will, typically we do questions at the end, and we will get to as many as we possibly can. If we are unable to get to all of them, we will send out a Q&A doc that has all of those on there. And I do want to make sure that everyone, our presenters and our panelists, are logged on before I go ahead and start. Let me just double check here. All right, I think everyone's logged on. Wonderful. Okay. Again, welcome. As Heather mentioned, this webinar is being recorded. Today, we are going to be talking with our subject matter experts at Healthcare Authority on some different topics related to prenatal, perinatal, maternal mental health, and health issues. We are going to go over the after pregnancy coverage. We will discuss Apple Health expansion and family planning only programs. We will also cover any program updates and reminders. We will have time for questions, and then we will do a wrap up. Our presenters that we have today, again, are from Healthcare Authority. We have Emily Good, who is a policy manager, Sheldon Pronte, a policy manager, Teresa Eltrich, who is the perinatal mental health program manager, and Beth Tinker, who is a clinical nurse consultant. And I will go ahead and turn it over to them. And you should have the ability to, make sure you have the ability. You should be able to pull up your screen, Sheldon, to present. Please let me know if it's not.
I think this is the first time I'm presenting in a webinar. Is it? Can you guys see it?
Yes.
Perfect. Hello. So I think Emily was not able to join us, so I'm going to be doing the presentation for APC and Apple Health expansion, and we're actually going to start with Apple Health expansion. And basically, this is just one kind of giant presentation. It'll I think it's about 20 slides for Apple Health expansion, then it'll go into just APC versus kind of two separate presentations. So just kind of a heads up for that. And as mentioned, my name is Sheldon Pranty. I am a policy manager with the Healthcare Authority and one of the co-leads for the Apple Health expansion program that we just implemented July 1st, and then also work with Emily on the APC program. So we will go ahead and get started here. So the topics of the Apple Health expansion presentation, we're going to review the current Apple Health programs and then go into Apple Health expansion, the policy and eligibility, of it, the ongoing application process, and managing the Apple Health Expansion Program. So current Apple Health programs today, so individuals who do not qualify for federally subsidized healthcare coverage because of their immigration status may continue to qualify for other Apple Health programs, such as the Medical Care Services, or MCS, Alien Emergency Medical, or AEM, Apple Health for pregnant individuals, after pregnancy coverage, which we'll go over in a little bit, and then Apple Health for kids. And then Apple Health expansion program policies. So as mentioned, where possible, Healthcare Authority use the same procedures as Apple Health, including the eligibility process, enrollment, redetermination, renewal process. The one thing I'll say for this Apple Health expansion was a capped program. We only received limited funding for the program. So even though we would like to cover everyone, there is a capped nature to the program. And at this point in time, we have hit that cap. So if individuals were to apply for the program currently, they would be denied due to no space available. But we're hoping in the future to get some additional funding so we can approve more people, or hopefully get to the point where there is no cap at all and anyone that applies can be approved. But as far as the program and everything, like I said, we're trying to mirror other Apple Health programs as much as possible. So if someone is currently on Apple Health Expansion, they go through their 12-month certification period and they attempt to do their renewal. If everything is still correct as far as their eligibility, they will basically renew into that same spot that they just previously held. And then one of the differences, though, from other Apple Health programs is this program does not have retroactive coverage. That was not something that was given to us in the proviso for Apple Health Expansion. So if an individual has a need for retroactive coverage, they can apply through the emergency medical program, potentially be covered under that if they have a qualifying condition in the retroactive months. And then if someone had a pregnancy that ended within the last 12 months and they meet the criteria for the after pregnancy coverage program, they can potentially receive that as well. And there is no resource or asset limit for Apple Health Expansion, and long-term services and supports will not be covered under Apple Health Expansion. And then just to clarify that too, there's two different age groups for Apple Health Expansion, which I think we're going to cover in the next slide. But just to kind of give some context, there are two different basically pathways to apply for Apple Health Expansion. One is for individuals aged 19 to 64. That is considered MAGI through Washington Health Plan Finder. And then for individuals age 65, it's kind of considered classic, where they go through DSHS, Washington Connection, and apply through that avenue for getting the classic side of Apple Health Expansion. So there's kind of two different spots there for individuals to apply, but the cap number that we have for the program is combined between those two avenues of applying. So just to clarify that. And then who is eligible for Apple Health Expansion? So Washington residents who are age 19 years and older, that have income at or below 138% of the federal poverty level, and then again are not eligible for other Apple Health programs based on immigration status or qualified health plans with advanced premium tax credits or federally funded medical programs. And then the managed care plans that are participating in the Apple Health Expansion are Molina Healthcare of Washington, United Healthcare Community Plan, Community Health Plan of Washington, and Coordinated Care. And then as other Apple Health programs work, coverage begins for new Apple Health enrollees, Apple Health Expansion enrollees, on the first day of the month they are approved. So if someone was approved 7/1, their coverage would start that day. If they were approved, say 7/27, their coverage would backdate to the first like our other programs would. And then changes made to managed care plans are effective the first day of the following month. So same process today to change a plan if someone needed to. So then the application pathways. So like I mentioned, there's two different pathways for individuals to apply. So those age 19 to 64 can apply through the Washington Health Plan Finder system, submit a paper application, go through an in-person navigator, or contact HBE or use the mobile app. And then acceptable forms of documents. So typically when people apply, if they've never applied through Health Plan Finder before, there's kind of an identification process that happens where the system basically verifies their identity or attempts to verify their identity. So there's not, duplicate applications being submitted from the same individual. So if someone is trying to apply for the first time, has never gone into their system before, these are some of the things that they'll want to hopefully have on hand when they're going through that process. So proof of identity, a driver's license, ID card, even if it's issued from a foreign country, any immigration documentation that they might have, a third-party affidavit or federal state agency letter confirming identity, and then household members not applying for coverage do not need to verify their identity. It's just the person that's applying for coverage. And then a social security number, if they have one, should be provided, but it's not required. And if they have an ITIN number, they don't need to enter that. And then the application pathway for those age 65 plus, like I mentioned, is through DSHS. They can go online through Washington Connection, call the customer service center over the phone, go into a local DSHS CSO office and apply in person, or submit a paper application. And if going through Washington Connection, if an individual comes into community service office or public benefit specialist, will be able to verify their identity. So it's a little bit of a different process from Helpline Finder. To help in the identification process, individuals should bring their most current documentation if they have any. For individuals applying online through Washington Connection, there is no identity verification needed to submit their application, as I mentioned, Helpline Finder does. So it'll all be manually verified once DSHS starts to process that application, and then it will be completed from there. And then just a note, if individuals are trying to apply for anything related to DSHS coverage, whether it's Apple Health Expansion or other programs, what they've indicated to us is the fastest way to typically do that would be through Washington Connection versus calling over the phone or trying to go into a CSO office. And then managing Apple Health Expansion. So as I mentioned, we're currently at capacity for the program. There's no spots currently available. We hit the cap for the program. For the Magi side of it, I believe on June 21st, and then for the DSHS side of it, because it is more of a manual process and it's a little bit slower, I believe we hit that on July 2nd. So with that being said, with the cap being met, individuals will be denied for Apple Health Expansion when they apply today. Clients can still apply for the emergency medical or AAM program if they have a qualifying condition. And then individuals denied in Washington Helpline Finder, due to the enrollment cap being met, will receive an eligibility notice with healthcare coverage options. And part of that letter will let them know that they can potentially receive a Cascade or pay for a Cascade Care Savings Plan if they enroll with that, and potentially get tax credits with that. And then continuing to apply for AHE. So even though we've met the cap for the program, we're encouraging folks to still apply for the program. And part of the reasoning for that is individuals who are denied are going to be put into, I won't say a pool because that's not necessarily the right wording, but just for the lack of a better word, we'll just say pool. So as spots become available, we're going to do basically a random selection of individuals, as we don't have an operational wait list at this point. It's something that we're trying to get in the future, but could be years down the road at this point, or months. So at this stage, we don't have a way to kind of hold people on a wait list. So for individuals that have applied and deny and are denied due to the cap being met, we're going to have them basically be randomly selected as spots become available. So obviously it's not a perfect situation at this point, but until we have the ability to have a wait list, this is what we've been able to come up with input from community and stakeholders outside of the agency. And for individuals that have been denied, they don't need to take any additional steps. We'll have them in that basically pool of folks, and they will receive an eligibility notice through their preferred communication method, whether that's email or mail, if they are selected for enrollment. And then for the applications ongoing, so even for folks that have been denied, and then say that, in a few months from now we have spots open up and we're potentially looking to randomly select folks, individuals should make sure that they keep their application up to date with any changes to their household income, address, or contact information. to make sure that we can get a hold of them if there are any changes in their household that might impact their eligibility. So this would be for Washington Helpline Finder and also for DSHS. And then if individuals are unsure if they've applied for coverage, they can contact the Health Benefit Exchange customer support team to verify their application for those age 19 to 64. And then for clients age 65 plus, they can contact DSHS or visit their local CSO office. And then for folks that are trying to apply, what do they basically need? So at this point, for both programs, like I said, it's mirroring typical Medicaid where we accept self-attestation of their circumstances. So if they were to apply, basically whatever they put into their application, the system will look at that and make a determination based off what they've entered. And then if that information is not necessarily incorrect, but doesn't match with our cross matches and other information that we have on file, then it will get pulled for what's called a post-eligibility review if they do get approved for coverage. So some of the things that we encourage people to have on hand when they're applying for just normal Apple Health programs or anything with DSHS is to provide wage stubs if they have any, receipts of their earnings, letter from their employer, or the ability to call their employer to get that information, or as kind of a last resort, their tax return, unless they are self-employed, which then that typically is preferred along with the 3-month profit and loss statement typically. So again, these aren't required at the time of application, but they do help for determining eligibility for Apple Health expansion and just any of our programs in general. And then Apple Health expansion outreach. So for the Apple Health expansion program, we did quite a bit of outreach and engagement with community, the TCAC, advisory committee, some other groups, and we did quite a few webinars and excuse me, and some other outreach things. And we did this flyer, we translated it into 15 languages with some information about the Apple Health expansion program and kind of what was coming and where folks could apply and what the program was about. And as I mentioned, we did several webinars. We actually did 2 on one day. One was in English and one was in Spanish. And if you guys haven't seen those yet, there's a lot of good information in there. I think they started in either January or February and went up until almost the end of May. Maybe I'm not sure if we did one in June or not, but did several over a few months. So like I said, if you guys haven't had an opportunity to view those, there's some really good information in there. And the link will be in the PowerPoint when it's sent out for you guys to be able to go view those if you haven't. And then if you wanted to stay connected about any changes with Apple expansion or any of the other programs or general information about the Healthcare Authority Apple Health programs, you can go to Gov Delivery and go through the subscription topics and click on Apple Health expansion, and you'll receive either an email or a text letting you know when any updates around the program happen. All right, so that was it for the Apple Health expansion program. So now we will go into the after pregnancy coverage.
Sheldon, Sheldon
Yeah.
and Talia, I do have a question for you that was asked regarding the Apple Health expansion.
Yeah.
If a client is on Apple Health expansion and they become pregnant and report the pregnancy, will they be transferred to pregnancy coverage then?
Yes, at this point, if they were to go into their application and report that they are pregnant, enter a due date, submit their application, the system will automatically put them on the pregnancy program.
Wonderful. Thank you.
You're welcome. Yeah, was there any other questions before I go into the APC?
I don't have any more yet for that section, so I think you're good to keep going.
All right, sounds good. All right, so the agenda for the APC presentation, given a little bit of background about the APC program, the eligibility covered services, the educational campaign highlights and the impact of APC, and then the resources for the program. All right, so background. So prior to the expansion of postpartum coverage in June 2022, pregnant individuals on Apple Health Medicaid received 60 days postpartum coverage that began the following month after the pregnancy ended. And then at the end of the postpartum period, coverage would then switch to 10 months of family planning only, pregnancy-related coverage. And this was a limited benefit package, which was mainly contraceptive care and family planning related services only. So basically after that first 60 days of, full coverage, it just went into family planning services. So there wasn't a ton of extra coverage there. So with Senate Bill 5068 passing in 2021 legislative session and signed into law in April 2021, the bill is designed to improve maternal outcomes by extending Medicaid coverage for 12 months after the end of pregnancy. So basically, instead of having 60 days of full coverage and then 10 months of just family planning services, it's now a full 12 months of full medical coverage. So the new program, after pregnancy coverage, or APC, was implemented in June 2022. And included in the bill was to do educational outreach about the extension. And then eligibility for the program. So after pregnancy coverage, eligibility is clients on Apple Health program are automatically eligible for 12 months postpartum coverage through the after pregnancy program when they're in the system. So if someone's pregnant, is currently active in Helpline Finder, basically whenever their due date comes due, the system will then automatically flip them to the APC coverage and the client doesn't need to take any action. Obviously, if their due date changed throughout their pregnancy, or if it ended for whatever reason, we would encourage them to go in there and update that due date so it correctly gives the right amount of coverage and puts them on the correct program. And I am sorry, my slides are skipping around on me and I'm not even touching my mouse. But basically we encourage folks to go in there and make sure that their information is correct throughout their pregnancy. And again, the transition is automatic, even if the individual reports a pregnancy and provides the estimated due date, and the coverage will begin the first day of the following month. The pregnancy ends regardless of the pregnancy outcome, and the coverage is for 12 months, regardless of how that pregnancy ended. And then new to Apple Health, so individuals not on Apple Health may apply for APC and must meet the following eligibility requirements: have had a pregnancy end within 12 months, reside in Washington State, have countable income equal to or below 193% of the FPL, and not be active in another Apple Health program. And then immigration status does not apply for the APC program, so it's for basically any individual. And then coverage begins the month that the individual applies and is found eligible. So the covered services for APC offers comprehensive coverage and mirrors the services covered during pregnancy and include but are not limited to physical health, so primary care, specialty care, urgent and emergency room care, behavioral health, mental and SUD, oral health and dental services, hospital services, inpatient and outpatient, and maternity support services is still only up to 60 days post end of pregnancy. And then we have a link that will be part of the presentation that gets sent out where you guys can view the more information on there if you would choose to do so. And then educational campaign highlights. So for summary, so we were given a $30,000 budget to reach intended audiences through social media, radio, community-based outreach, and publications for when the program first went live in June 2022. So there was a lot of outreach done. I think actually Melissa Rivera, I think is here from Healthcare Authority. I think she actually maybe did the radio ads back when that happened. So we did a lot of outreach trying to get the word out about this program because it was something that was in the works for a long time and is obviously very beneficial for individuals. So we tried to do the best we could as far as getting that word out so folks could get on this program. And then Gov Delivery messaging. So Gov Delivery messages, including links to materials, we sent to various provider types: family planning, reproductive, tribal, rural health clinics, and behavioral health. So these are some of the things that we sent out. And then we also have our APC webpage where folks can go and learn more about the program and see what actually is all on there as far as how do you apply, where can you get more information, am I eligible, and just some more information about the program in general. And then we do have an APC flyer that kind of goes over what's available in the program, how you apply, the eligibility, that's available in 15 languages and is also on our HCA website. And then we have the APC poster. It's 11 by 17 as a QR code for APC, and printers can print and display in their facility. So this is something, if you are part of a provider's office or clinic, you could have this in your facility and folks could just scan the QR code and get information on the program. And then social media. So we have a social media toolkit. We shared on Facebook, Instagram, LinkedIn, and X, formerly Twitter, about the program and trying to encourage individuals to apply for this program. So again, for folks that were already pregnant and were in the system, all this, when this went live in June 2022, this all was automatic for them. They didn't have to do anything. So for folks that may not have met the criteria or had a pregnancy that happened at a certain point, this is more for those folks trying to encourage them that they might be eligible to apply for the program. Because like I said, if you're already on it, you automatically get transitioned. You don't need to take any action. So again, for radio ads, we did live stream covering Yakima and Tri-Cities. We did iHeartMedia statewide, and then also radio covering in Seattle, Tacoma, and the Spokane area. And then Spanish, we did Northwest Greater Seattle area, South Puget Sound, Tri-Cities, Central and Eastern, Othello Moses Lake, and then the Yakima area. And then current and upcoming listening sessions. So HCA is partnering with DOH, who have grant funding. So we're funding community-based organizations to host listening sessions. And the purpose is to hear and learn from clients what are barriers or facilitators for accessing Medicaid covered services in the area post end of pregnancy. And we have a hypothesis, but want to hear directly from clients. And then the DOH will complete analysis, so the data will inform next steps in terms of how to assure clients are accessing services they need and desire in the year post end of pregnancy. And then the impact of APC. So the impacts, so HCA conducted internal evaluation, and part of this was maybe a little skewed because of the public health emergency and continuous enrollment. So the data claims maturity, we also looked at those things, the evaluation design and analytic approach. So for eligibility, how are people being enrolled into APC? Service utilization, what services are being accessed in the year post end of pregnancy. So basically when someone has this coverage and they go to the doctor, like what are they going to the doctor for? And then the cost is another thing that we were looking at in the early and preliminary findings. So eligible population with low utilization of services, lower than anticipated when looking at a comparison group. So again, kind of with APC is obviously something that's very impactful and helpful for folks, but we're not seeing a lot of individuals who aren't already on pregnancy apply for this program, even though we've been trying to get that out there. So looking for kind of some more reasoning behind why they wouldn't be applying for this program if they have heard about it, or maybe it's because they haven't. So trying to delve into that a little bit more.
Hey, Sheldon, this is Beth. Do you want me to take these ones? Sorry.
Yeah, sure. If you want to, if you have more thoughts.
I feel like you were like, maybe she's not here, and so she's in that. No, you did an awesome job. Hi, everybody. This is Beth. I can just add on. I've been more involved with the evaluation. So happy to weigh in here. Although Sheldon was doing an awesome job, I would just point out in the early preliminary findings piece in the comparison group. I mean, the reality is we don't have the comparison group that we would like, right? Because really to measure or evaluate the impact of APC, we would want to compare the currently covered population, which again has been now since June of 2022, with folks who only had the prior 60 days, approximately 60 days of post-end pregnancy coverage, right? And then lost coverage. But we don't have that comparison group, right? Because we don't have any claims data on people who aren't covered by Medicaid. So that's just like an inherent gap or methodological and data challenge. So the comparison group we looked at, which is by no means perfect, although it's what we have, we looked at people capable of pregnancy or females in sort of the reproductive health years that are on expansion coverage, so other comprehensive Apple Health Medicaid coverage, and looked at utilization of services And so what we found is that it certainly appears that folks who are on APC, the 12 months of comprehensive post-end of pregnancy coverage, are utilizing significantly less services than the comparison group. And so I think we're curious about that, right? And this loops back to the slide before, and really thankful to our DOH partners for helping and partnering with us on some listening sessions to actually hear from clients around what helped or facilitated you getting services in that year post end of pregnancy when you were on APC, or what were the barriers and how can we, overcome them. I think this group obviously is very attuned to this population. And I think it's fair to think that folks in that year post-end of pregnancy at the population level do have healthcare needs, and desires that Medicaid covered services could potentially be, a support for, something that they would be interested in. And so I think we are in this place of just trying to better understand what is getting in the way of folks utilizing their APC, because the policy itself is not necessarily beneficial. You could argue that the policy is beneficial, it gives people coverage, but what we really want is for our clients to be able to access the services, right, that they need. And so we're like, do people not know that they have APC? We've heard from a couple of community partners that perhaps public charge is an issue and a concern with this population and utilizing their APC, right? So that could be that folks know that they have after pregnancy coverage, but they're just not using it. So again, listening sessions hopefully will shine some light, give some more context into the actual client experience. But I think the overall tagline is we are surprised that utilization of services seems pretty low for the population in that year post-end of pregnancy. Okay, and then next slide, and then this is the last one, and then we can have Q&A on APC. So I teed this up, right? I probably already said everything on this slide. People who know me are like, oh my gosh, Beth, you just talk so much. Opportunities for improvement. So pending what we learned from listening sessions, like again, we have some hypotheses, but really curious and excited to hear what the themes are that come out of those listening sessions. Certainly look to you all and other partners across our communities, people who are working directly with the population of birthing people, pregnant people, post-pregnancy people, making sure that clients are reporting their EDD or their end of pregnancy date when pregnant to the HCA. The reason for that is so that folks will be rolled onto APC and they won't experience any gaps in coverage. These are the variety of ways that pregnancy, end of pregnancy or estimated end of pregnancy can be reported. And then, if you all, can help share messaging around APC with your clients, with your families, if people need help accessing a primary care provider or other service provider in that year. I know this is the work of MSS and ICM providers. I know many of you, I was one myself. So, right, always, connecting families to things that they need and that will benefit them is, absolutely part of that work. So I think that's the end. Oh, resources.
Yeah,
Sheldon, maybe back to you. Yeah.
I was gonna say I can take it here. Thank you for jumping in. So like I said, this was kind of a combined presentation since we were kind of covering two topics there at the beginning. So these first resources are related to app health expansion. So if you guys wanted more information on anything we went over for the app health expansion, here's some resources to be able to look at. As I mentioned, like the cap enrollment announcement that went out from the Healthcare Authority will be part of this, and you guys can review that if you want to. And then web resources for after pregnancy program that we just went over. A link to our webpage, some information on just the pregnant individuals in general, if you guys wanted to go check that out, and then stakeholder training and education, some resources for that. And that is the end of our presentation. So any questions?
Thank you so much, Sheldon and Beth. I do have some questions, so I will go ahead and ask those. Our first question is asking, is home health postpartum nursing care a covered benefit under APC? If so, what's covered?
Oh, okay. Home health, postpartum. I just popped up the Q&A. Super helpful. Thanks for the question. I hope I'm gonna say your name right, Kiana. Are you talking about skilled home health nursing?
And Kiana, I can unmute you if
Oh,
you,
sorry.
no, you're fine. If you would like to clarify and ask the question, I do have that ability too. So I think if you raise your hand, you're able to ask the question too.
The answer is yes in the Q&A.
Okay. So Heather, we are currently doing some inquiry around skilled home health nursing and sort of the pregnant postpartum population. It's a really great question. I'm going to caveat this by saying the home health billing guide and program and associated services are are in the scope of some of our other colleagues, so it's not our area of expertise, but we are interested. But I believe those skilled home health nursing is actually not currently covered in our policy for postpartum people broadly, like irregardless of APC. The eligibility criteria for skilled home health nursing, as described in the billing guide, there are criteria for pregnant folks being eligible for those services. If I'm remembering, the categories are folks who are at risk of preterm birth, folks who have hyperemesis gravidarum, folks who have a PIH, pregnancy-induced hypertension, and folks who have gestational diabetes. But again, current policy is only during pregnancy. So the answer to your question is no, that is not a covered benefit under APC. It's also not a covered benefit more broadly, but we are actively looking into it.
Wonderful, thank you. I do have another question. I do have a few people who raised their hand to ask questions. So, Jesus, I have your hand raised. I can unmute you if you'd like to ask your question. Just one moment. Oh, it looks like the hand went down, so that's okay. Tanaya she has a question as well, so I will go ahead and unmute you. All right.
Thank you.
Yep, you're good.
Yeah. So Sheldon, a few slides you said that HCA had hypotheses for folks not enrolling in Medicaid. Would you mind disclosing that hypothesis?
Yeah, I think Beth, I think that might have been,
Is that Beth's hypothesis?
yeah, I think so. Sorry.
Oh, was that on the slide? Our hypotheses around folks not
Basically why it's
wasn't-
it's basically being underutilized. So kind of a hypothesis of why maybe that was happening, I think.
Yep. So tonight, just for clarification, and maybe my language wasn't clear on the slide. Sorry. Not hypotheses around people not enrolling in APC, but around not utilizing the APC
Oh, okay.
services, which I think I already mentioned.
Yes.
Does that help?
Yes.
Yeah.
Yes. Thank you.
You're welcome.
Thank you so much. I do have another question from Sherry, and I'm going to unmute her so she's able to ask that. So just one moment. All right, you should be good.
Hi there. So it's more of a comment than a question around the APC and the lack of utilization post-pregnancy, of course. In our experience, I work with a certified nurse midwife, nurse practitioner here in Colville, and our experiences are more around the fact that we find parents tend to not want to pack everyone up and head into the office. And so our ability to meet that need is to do a home visit within 24 to 72 hours post-delivery and then possibly a 10-day if they're still not moving around very well. Although we do utilize doulas for in-home postpartum support as well. And also that we notice other APC style appointments, like a 6-week postpartum or memos or anything like that. Our families are indicating a lack of childcare, and again, not wanting to pack up the whole brood and head into an appointment for said service, especially if it's any sort of imaging. So just around that need for, of course, we know critical childcare support in that space. And then my other thought about this in the postpartum nursing support in that skilled space, would the nurse family partnership be comparable to providing that postpartum in-home support services?
Oh, yeah, Sherry, that's all really helpful. Appreciate your insights and like specifics from you're in Colville, right?
Yes, I am. Hi,
Yeah.
Beth.
Yeah. Nice to hear your voice. I totally think, right? Like, yeah, are we providing, delivering care in the models and settings that people want, right? I mean, that's sort of what I'm summarizing it.
Yes.
And like, I think that's absolutely true. How we solve those problems, yeah, that's an ongoing challenge. So I totally agree with you. That absolutely aligns with my experience working very much with families in early life. Is the last thing people want to do is, yeah, pack up their new baby, other kids. Certainly childcare is an issue. Going back to work early is an issue, like all the things. So I think there's many contributors to what we see as low utilization of services. And I think we should continue to understand the family experience and then what potential solutions are to that. I don't have an answer. I agree with you, basically. The NFP question, I am not an NFP nurse, so I don't want to speak like I am, but I'm very familiar.
Right.
I think skilled home health nursing is quite different and distinct from NFP. The skilled home nursing that we're talking about is provided through skilled nursing agencies. The visits are usually quite short and focused on like specific. Again, we can reflect back on what the eligibility criteria are for us. And so like, focused on the gestational diabetes or on the hypertensive disorder of pregnancy. And NFP is just so broad. It's so relational, NFP. And
Yeah.
that is not my experience of home health nursing. So I think they are quite different. Doesn't mean that people couldn't benefit from both, of course, but
Right. Yeah, this definitely sounds like a higher level conversation to continue having, because we here in Colville are actually talking to our providers about those who might be interested in doing those home visits again. But I know certain entities have issues with allowing their providers to do home visits. So lots of conversations still happening, of course, and needed everywhere.
Yeah.
Thank you.
Sure.
Thank you. The next question I have is, will APC cover doula birth postpartum services? What are the requirements or resources for doulas to register with APC?
Okay, I can take this one too. Leslie, thanks for the question. And super happy you raised it, because I think there's lots of confusion around doulas. And actually, Heather and Shuli, I just recently said maybe we should have doulas as a separate topic for this group upcoming. So excuse me, everyone, for taking advantage of having the mic per se, but I'm going to take advantage of it and say so in this past legislative session, HCA was directed and funded to implement a Apple Health Doula benefit. We are actively working on that, but we do not currently have an Apple Health Medicaid reimbursement for doulas. That is in process. We are targeting early 2025, so like first quarter calendar year of 2025. There's multiple pieces to implementing a brand new benefit for a brand new provider type. And there's some timelines that are, out of our control to some degree, like CMS approval. And so that's why we can't have a firm sort of target date, but we seem to be on track so far for early 2025. We intend for the doula benefit to the eligible population for the Apple Health doula benefit to be all folks on Apple Health who are pregnant and inclusive of that full 12 months postpartum. So that will be the eligibility for doula services if a client is interested, and of course able to engage and partner with a doula, right? So there's always, these factors, call them access broadly, and all the components are going to access. We've already talked about others. So yeah, so that will be the eligible population. So folks on APC, because who is on APC? Folks who had, doulas will also be available. The benefit will include any end of pregnancy outcome. So, right, so it's not just going to be a live birth. It's going to be, a stillbirth or fetal demise, an elective abortion, a spontaneous abortion. All of those folks, as they desire and can access, right, would be eligible for the doula benefit. So it will not be exclusive to APC, although, again, we hope that the vast majority of that population, 12 months and a pregnancy, is on APC. Doulas register with APC. Doulas will not have to do anything specific with APC after pregnancy coverage. Doulas will have to get the Department of Health voluntary birth credential that has been set up from our partner sister agency, Department of Health, since October of 23. Yep, that's right, October of 23. So if doulas are interested in being a doula and getting reimbursed by Apple Health, they first will need to get the voluntary birth doula credential with Department of Health. Then they will need to enroll as a enrolled provider with the doula taxonomy with the healthcare authority. Those are kind of the steps. We need to have the reimbursement actually implemented in place, which again, we're hoping will be early 2025.
Wonderful, thank you. The next question asks, will FQHCs be able to bill for the doula benefit?
Brienne, thanks for the question. I'm assuming you were talking about the encounter rate, and our FQHC finance experts at HCA have informed us that the doula services will not be FQ encounter rate eligible.
Thank you. And I think that may be the questions for this topic.
I have one quick one for Sheldon.
Oh, yes, go ahead.
Touch on both your presentations, Sheldon. So if somebody is on APC and it's about to end and they want to get on the waiting list for Apple Health expansion, do they need to wait until their APC has ended, or would they be able to submit that, say, that last month of APC eligibility?
No, that's a great question. No, so yeah, if they are on APC or any of our other programs, and once say their APC coverage ends and they're not eligible for anything else, they'll basically be denied at that point, right? And then from there, they'll go into our pool of individuals that we would potentially be randomly selecting from. So yeah, they wouldn't have to necessarily do anything. But like I said, obviously we would want them to update their information. Because honestly, if someone goes in, reports they're pregnant, they're on pregnancy coverage, they go to APC, technically they don't really have to touch their application for 2 years, right? Because it's just going to kind of automatically roll them from one thing to the other. So we would encourage people to make sure that they are going in and attempting to renew and updating their application. But as far as them necessarily having to do anything, they'll automatically go into that pool of folks that would potentially be selected.
Thanks.
Yep.
Thank you, Sheldon. I do have a few more questions that came in about doula, so hopefully, Beth, you're able to answer a few more questions for us. What will be the billing process for doulas. Will that be directly through P1?
Shalia, I have an update on our doulas is included on slides. I think doula questions, if we have time, because we're kind of running low on time. I'll try to answer those, and then if not, we will do a Q&A that we'll send out with the email, and we can definitely have Beth answer these if they're not answered during our updates.
Perfect. Wonderful. Okay. We will go ahead and move on to the family planning only coverage, and Beth will be presenting on that. So I will share my screen. So give me just a moment and we'll get that up for you guys. All right, if you will let me know, Beth, if you're able to see your slides.
I do see them. And Shalia, so is Teresa following me with the perinatal mental health?
Yes. Would you prefer if she goes before you?
I just don't want to take up her time. And you guys, how much time do you guys need for updates? How much time do we have left? I guess that's my question.
We have what, 35? Am I doing that math correctly? Yes. 10 to 11:30 is going to be the end time. So it's up to you on if you want to go or if you want to let Teresa, if she's ready.
I'm going to try to go through these quickly.
Okay.
I imagine there won't be questions, or not as many. Family planning only has been around for a long time. Okay. Hi, everybody. Next slide, Shalia. So what is family planning only? Covered. How to apply those? I'm totally going to breeze through. References will be in the slides if folks need those. And then care coordination and continuity is kind of why we decided to revisit family planning only. So next slide. So what is FPO? Next slide. Thanks for driving, Chilia. Stresses me out. So family planning only is a limited, here's like the taglines, right? It's a limited benefits and services package or limited coverage. It really focuses on family planning services as defined by contraceptive care and other sexual and related health services. How is it different? I think these are always important, like key messages. How is family planning only different? One is the income eligibility. It's notably higher, up to 260% of federal poverty level. Offers confidential coverage. Also, non-citizens are eligible. Of course, that is also true of some of our other coverage, but it's true for family planning only. We have what we call a state lookalike for family planning only. So there's both a federal waiver arm and then a state only arm. The services and coverage match though. So from the client perspective, family planning only has the same coverage. It's for 12 months duration. When improved, clients can reapply every year as long as they still qualify. They can get it year after year, and just a couple of links here. Next slide. What is covered? So again, everything on this slide is not new. So I'm probably going to just kind of scoot through to some recently added benefits. So next slide. You guys might want to view that FAQ if you're so interested. You know, we do like to call out permanent methods are covered. This is for people capable of pregnancy and people with a penis. We have super low utilization for males or people with a penis and family planning only. There's probably a lot of reasons for that. But you know, good for us all to know and remember. And you know, permanent methods like vasectomy, also bilateral tubal ligations are covered. So the new services starting in January 2024, we added HIV and viral hepatitis B and hepatitis C testing to the benefit package for family planning only. We also added, we essentially added hepatitis B vaccine, but we also added the combo Hep A and Hep B, recognizing there are some clinics that really may only have the combo Hep A and Hep B, but with the tie to family planning and sexual and reproductive health, it really is, the driver there is the hepatitis B. Next slide. Important to know, in policy, we cover a 12-month supply of client voice and choice in terms of contraceptive method. We know that clients don't always get a 12-month supply. That's probably a different and separate conversation, but in policy, we do cover a 12-month supply, and that should be driven by client choice. And yeah, I think we can move on. How to apply. So again, I think these are just links. If folks don't have these, Andrea Estes, her email's here on the bottom. She's our Sexual and Reproductive Health Programs Innovation Manager. I think a lot of you know her. She's wonderful. She's very responsive. If you have specific questions, she's a great person to reach out to. Next question. Sorry, next slide. Confidentiality. So we do like to elevate this whenever we talk about family planning only. We have a protected status flag in provider 1 if clients are requesting confidential services. They can choose any address. I think all of you pretty much are really familiar with this because of the work you do and the population that you work with. So we can go to the next slide. More resources here, supports, call center numbers, provider lines, both for claims, so more for billing questions, or other provider questions. There's also a separate option in the phone tree for students or adolescents. Okay, next slide. Care coordination and continuity. So just wanted to flag a couple of things with these other conversations today around Apple Health expansion, of course, and APC or after pregnancy coverage. How does family planning only sort of fit into, right, the larger landscape or the system of all the sort of coverage that's available to clients? Important to call out, family planning only does not cover pregnancy or pregnancy-related services other than pregnancy testing. So, and this is irregardless of what the client decides about the pregnancy, right? So I say that to say clients who are, well, if they're unsure what their decision is around the pregnancy, if they are seeking clinical pregnancy care to continue the pregnancy, if they are seeking to terminate the pregnancy, family planning only does not cover any of those associated services. So clients need to contact HCA, report their pregnancy, and then get on the appropriate coverage. I think I hit those high points. We've talked a lot about after pregnancy coverage. Yeah, that was perfect. So how does APC sort of relate to family planning only? Well, after your clients are sort of reaching that 1 year post end of pregnancy, any outcome again for pregnancy, they are not going to be eligible anymore for APC. So they are essentially going to lose coverage. If that client is eligible for another comprehensive, like an expansion plan, that's great. We always support clients having the highest level of coverage possible that they are eligible for. If they want that, it is of course their choice. But so there may be clients and families that you are seeing who are going to lose their APC, right? So like ICM families, same sort of timeline here, right? And if that client has an ongoing family planning contraceptive care need, they might want to apply for FPO. So that's sort of what I see as how these things play together. Also just noting again, the higher income eligibility for FPO. So very much could be people who with expansion coverage at 138% of FPL. There's certainly folks that fall between, right, that are not income eligible for expansion coverage, but again, may be eligible for FPO. Again, highlighting here again, the confidential coverage is another piece or advantage to family planning only. And again, gender's not eligibility criteria. We overwhelmingly, I think Tanaya's on here. What, Tanaya, like 98% females, people capable of pregnancy? Like it's overwhelmingly people capable of pregnancy. And so we just want to remind all of our stakeholders and partners that anyone can be eligible for FPO. It is not gender-based. And I think maybe that's it for me. So if there's questions, great. Otherwise, I think Teresa's up next.
Wonderful. Thank you. Let's see. I don't see any questions about this section now. We can continue on to Teresa's section if you would like, and then we can answer any questions if that works. Give me just a moment and I'll pull her slides up. So whenever you're ready, Teresa.
All right, perfect. Thank you so much.
Thank you.
Can you hear me okay?
Yes.
All right. So I am, my name is Teresa Eltrich. I am the Perinatal Mental Health Program Manager here at the HCA. And I am going to be sharing some perinatal mental health updates. So really our goal is to improve awareness across the state. And I'm just going to go over a little bit of why this is important and kind of move into what we're doing. So this is important because 96% of our birthing aged American folks live in maternal mental health professional shortage areas, which means that there are blackout areas, where there aren't enough providers, there are not enough resources, people don't know about the resources, etc. So with the births in Washington, there's a graph that I attached, and you'll be able to access that in the documents that are sent out after this webinar. But in 2022, a little over 83,000 births were in Washington, and of those, nearly half were Medicaid live births. That is not including the losses, regardless of loss or stillbirth. Perinatal mental health impacts 1 in 5 individuals, so this is a pretty significant issue, and especially if it's not addressed or awareness isn't reaching all areas to provide support. Next slide, please. So as far as improving awareness across the state, one of the things that we have been doing is trying to get involved and be able to connect with other states and folks doing some of this work as well to kind of compare and explore things that Washington can implement, maybe that we're implementing already that other states aren't, which we have been doing a lot of work and moving forward that other states have been really interested in as well. So in doing so, we applied and were accepted and selected to participate in the SAMHSA Learning Collaborative related to perinatal mental health. So we had to select a goal and one focus that we were going to work on over the period of the kickoff was in March and the final presentation is in September. So it was kind of a short-ish amount of time to get things started. But as you'll see in the next few slides, we have actually had pretty good success with our goals and working towards the future and implementing some of those goals. So our goal and focus was on improving access to care and awareness of perinatal mental health related issues and concerns. So I can go ahead and share we've been working on in that. Oh, and we also were selected as one of 8 states to participate in this. So we were really lucky to be included. So one of the things that we focused on as far as improving awareness was to really have exposure across the state about maternal mental health and perinatal mental health. And to do so, we requested a proclamation and the governor granted it as May being Maternal Mental Health Awareness Month. And this was the first time for our state to do so. So we were very excited about that. We did a couple different things to support improving awareness and a couple different events. One was a virtual statewide where we just kind of talked a little bit about perinatal mental health, how it's impacting our state. Again, talking about some of those blackout areas and some of the barriers to care. And we had 2 really great speakers come and visit us. They're nationally renowned speakers. So we were super lucky. They're both wonderful, wonderful people doing amazing things for this for this population. Kay Matthews with Shades of Blue Project spoke about the support of BIPOC community as well as perinatal loss families and improving awareness around that and how it impacts maternal mental health or perinatal mental health. Joy Burkhardt with the Policy Center for Maternal Mental Health also was a speaker and talked about Washington's scorecard and how we are doing and in relation to other states. And we're actually, I believe, in the top 5 that received high scores. So we're doing really well. We still have a ways to go and things that we need to do. And hopefully some of the goals that we have identified through the Learning Collaborative will help us get there. So that was a virtual celebration that we hosted in May. And then the governor actually requested a roundtable and a panel conversation with just a really intimate group of providers, community partners, and lived experience voice to come and share some of the needs, some of the things that are being done in the communities, and what we know to be barriers to care and what we can kind of do to come together and support that work. We also had partners from the Department of Health and DCYF, which was great because it was a cross-agency support for this identification of this month. So that was great. And we'll go ahead and go to the next slide. So along with that, improving awareness across the state, we have worked really hard to get reimbursement for perinatal mental health screening. This ideally will improve awareness across the state as well and improve access to resources, whether that's mental health treatment, getting folks connected to different resources that can continue to support recovery for those families. So providers can screen up. Pediatrician providers can screen up to 2 caregivers per visit. Caregivers are defined as any individual that's caring for a child. So it doesn't have to be only parents. It can be foster parents. It can be grandparents. It can be a parent and a partner. So it really doesn't matter if they're caring for the child, they can be screened. Providers are asked to identify the outcome of the screening with a modifier on their claim submission. So we are hoping to get some data back to see what that looks like for our state. And so we've been trying to really give information out about providers being able to screen and what that looks like. So screening can be offered during the perinatal period by OBs and medical professionals, as well as pediatricians now in the first year after birth. So any well child visit, any check-in to be able to support those families. There's more information and guides on reimbursement and screening at the HCA billing guides pages. And that is a hyperlink. So when you get these slides, you can connect on there. And I think it's probably in Beth's too, to be able to click on that. So as far as also improving awareness across the state, we're trying to get awareness of supports for families and providers that serve the perinatal population. The PERC Center at UW has quite a few different resources. They're dedicated to transforming perinatal mental health and substance use systems through consultation, education, and research. And if we, let's see here, skip down to the MAP Echo right there, they actually are offering an Echo series. So for providers that can get continuing support, being able to consult about cases, listen to cases, be able to get support that way in education. The perinatal PCL is a free state-funded program for providers to access that they can consult about a perinatal patient or client. And this is a provider-only line. So, and then the MAP Echo series is also provider only. So we're really trying to get information out for providers to get more education and to have community that they can access to get support in caring for them. Next slide, please. All right. And then some of you might already be familiar with PS Washington, but they have a lot of different resources for parents and providers. They have the Warm Line that is a call answering that offers warm handoff support and education as needed. There are also various educational opportunities for providers. So they have peer trainings, they have provider education on ongoing trainings, and different resources, webinars, things like that folks can access. And then they also have referral resources. So providers can access that to get patients who maybe they're doing screenings on connected with a support group or a resource for therapy, things like that. There's also content on the HCA website. We've been working really hard to be able to get information for folks to have access to get some perinatal resources. So we have information on birth, pregnancy, hotlines, screening and symptoms, things like that. So there's a link down there also. So pregnancy care resources on the Healthcare Authority webpage. There are a lot of different things that providers and perinatal populations can access. Next slide, please. And then there's just some different citations here. I just included the information about the dark zones that they're talking about with relation. You can go on there and you can select your county and see what that looks like. And then they also have the scorecards that I was talking about with our virtual celebration that Joy Burkhart talked to us about. And then some of the other links for the different resources that I mentioned in here too. And I think that's my last slide. So we're working really hard. We've had a couple accomplishments with the Learning Collaborative. So having the Maternal Month of May has been one, the screening has been one, and we're working on improving communications across the state. So keep an eye out for that.
Thank you so much. That was wonderful.
Great, thank you.
Yeah, I'm looking to see if there's any questions. I don't see any right now. Let me just double check in one more spot here. Okay, great. All right. I am going to, if you guys have any questions, please put them in the Q&A. Oh, looks like we do have a hand raised. Sherry, I'm going to unmute you. Here we go. Well, possibly. It doesn't look like it. Hold on just a moment. Oh. It looks like your hand went down, so that's okay. Oh, it's back up. Okay, let's try this again. There we go.
All right, there we go. Thanks. Hey, I was just wondering, in regards to the billing fee schedule for the HCA, because again, yes, my area is also one of those blackout zones for services. I'm trying to work along the lines of the HCA opening the doors for associate therapists to bill. I do understand that it is for fee for service only or BHSO only style billing. I'm wondering if there is any idea if a pregnant person wants the mental health services from an associate, are they able to remove themselves from their MCO and go FFS for that reason? That was a big question, sorry.
Those are good questions. I think there is an email address that I'm happy to send over to you for questions like that you can kind of get maybe some more clarification on.
Great, thank you.
Yeah. And I can give Shalia and Heather to put in the email out.
Thank you.
Appreciate it.
Sure.
It looks like I do have one more question. It's asking, are you aware of WSHA's Perinatal Mental Health Collaborative and AIM's bundle rollout?
Can you repeat that first part?
Yeah, of course.
Sorry.
No, you're fine. And so are you aware of, they're using the acronym WSHA's Perinatal Mental Health Collaborative and AIM's bundle rollout?
Yes. Yes, I have been involved in speaking with them.
Wonderful. Great. Thank
Yeah.
you.
Mm-hmm.
Right. Wonderful. Thank you so much. We appreciate you guys taking the time and talking to us about these different updates. It's been very helpful.
Thank you for having us.
Yeah, of course.
It's nice to share all this great information.
Yes. All right. I'm going to go ahead and pull up the rest of our slides for HCA and program updates, and I'll do that now.
Right, thanks. So I may go quick through these because it looks like we just have about 10 minutes left. And then definitely any questions you guys have, please submit them. And then we will do a Q&A document that will attach to the email with the recording and all of the wonderful presentation slides that the presenters have sent. So one of the updates I wanted to give is in regards to the MSS screening tools. And this is something that came from Senate Bill 5580. That was the bill where there was part of the bill is in relation to making some improvements to the MSS program. So we are currently working with HCA IT staff regarding that requirement within Senate Bill 5580 to develop a mechanism to collect the results of the MSS screening tools. This, we will be moving forward with putting the current MSS screening tools into an online system where the providers will be able to enter the screening results and HCA will be able to capture and collect the results entered. This is something we've been wanting to do for years and haven't had the capability to do it. And now we're moving forth and it looks like we may be able to get that to become a reality. We will definitely be keeping you apprised of the online system as we learn more because there's still lots for Shalia and I to learn. And we will be asking for a few providers to volunteer to test out the new system before we do go live. So we will definitely be providing some training and hopefully some screenshots and having a few providers helping us out by using the system before we require everyone to use it. We hope to begin updating the MSS screening tools after this next legislative session. So we'll be using the current screening tools first, and then we're hoping that the current screening tool will be updated. As I've stated before, there was no funding for full-time employees for the work to be done in Senate Bill 5580. And one of the full-time employee FTE requested is for HCA data, which would be to help update the screening tools to be culturally relevant and include current risk factors since it's been 15 plus years. I think it's been about 16 years since the tools were developed. And so a decision package is currently being drafted to request funding for FTEs. And we're hopeful that we'll be able to get some funding so that we can complete the work that's required of HCA in Senate Bill 5580. Next, and I'm hoping chat works because I can't enter anything into the Q&A portion. So hopefully everybody's able, we have chat kind of not available for people to enter in. We ask that you use Q&A. So hopefully me putting in this website is available for everyone, but I wanted to let you know that the telemedicine or telehealth billing guide was recently updated. And as a reminder, billing guides are generally updated quarterly, so you'll want to periodically review relevant guides, which includes telemedicine, if you provide MSS via this platform. And then, of course, if you're an FQHC provider, to periodically review the FQHC billing guides. So to comply with Senate Bill 5821, audio-only telemedicine now requires an established relationship between the healthcare practitioner and the client. And so what I'm going to read here is what's in the billing guide, the telemedicine billing guide. As we reference that guide from the MSS billing guide and any telemedicine services provided through MSS. So RCW 74.09.325 defines an established relationship as a relationship between a healthcare practitioner and an Apple Health Medicaid client in which both the following are true: that the practitioner providing audio-only telemedicine has access to sufficient healthcare records to ensure safe, effective, and appropriate care services, and that the client meets either of the following: has had within the past 3 years at least one in-person appointment, and that in-person appointment can be a telemedicine real-time interactive appointment using both audio and video technology with the healthcare practitioner providing audio-only telemedicine, or with a healthcare practitioner employed at the same medical group, clinic, so same MSS provider. Or if you're providing MSS within a clinic system, then that would qualify as well. And then the other is if they were referred to the healthcare practitioner providing audio-only telemedicine by another healthcare practitioner who has had within the past 3 years at least one in-person appointment, or again, at least one real-time HIPAA-compliant audio-visual telemedicine visit with the client and has provided the relevant medical information to the practitioner providing audio-only telemedicine. So previously, audio-only could be the very first visit, but now it has to be if it's an established patient as outlined in the telemedicine billing guide. So I would definitely encourage that you go to the telemedicine billing guide to look at that update. And then I'm also putting in brand new, it sounds like, just published webpage on HCA's website on the provider billing side in regards to doulas. So HCA is currently working with CMS to finalize the state plan amendment to include birth doulas as a reimbursable provider type, as Beth said, beginning early 2025. Draft WAC, Washington Administrative Code language is also being written, and HCA is hosting a doulas community meeting tomorrow evening from 6 to 7:30. And so if you look at that website that I just put in the chat, you can see there's the Zoom link, no registrations required. So there's a link there. And then also if you scroll down on the website, there are recent bulletins and newsletters that were sent out. And there's one that includes information about the meeting. And it also includes the documents, the draft documents that will be referenced in the meeting. There's also a link to sign up and subscribe for the doulas GovDelivery mailing list. So if you want to be kept apprised of what's happening with doulas, I definitely would suggest that you get on that GovDelivery topic. And then also towards the bottom, there is a specific email if you have any doula questions of HCA. There's a specific HCA doula email. And so looking at WAC and some of the questions that were asked previously can be kind of answered through that. It's still, there's not a, it's still not currently covered, as Beth had said, but we're currently working on WAC, and then there will be a billing guide, and a lot of the questions that I'm sure everyone has will be answered as things get closer, but definitely I would save this website and go back to it periodically for updates. And I think it may answer a lot of questions you may have. Also with birth doulas, that a new doula program manager has been selected and will begin at HCA on August 1st. And so as we did kind of with Teresa and introduced her to you guys at one of our webinars, we'll hopefully introduce you to the new doula program manager as well. And then hopefully I left you enough time, Shalia, to do your section. Sorry.
Oh, you're fine. We just have a few minutes. So really quickly, I wanted to talk about ICM EPA, so that's the expedited prior authorization use. We continue to see the EPA being billed and used on claims inappropriately. So just as a reminder, the EPA must only be used when all of the criteria is met, which includes the infant meets all of the ICM eligibility as listed in the MSS and ICM billing guide. The infant's eligibility for ICM begins during the second month of life. And we do have a newborn calendar, and we will definitely make sure that that's included in the materials for you. And ICM services are provided during the infant's second month of life. So the reason that we have the EPA is so the Provider One system is limited in that it only can count months and not days. So because of this, we had to create the EPA for those infants whose eligibility starts within the second month of life and not the third. And the services are provided within that second month. So without the EPA, those claims that meet the criteria will deny in the system because it's identifying and it's saying, hey, that infant's not eligible for services yet. So when the EPA is used and it's not necessary, it is forcing claims to go through that do not meet the criteria. So we just want to make sure that, you know, the EPA code is used appropriately because it is forcing certain error codes as well. And so I do generate a report on a quarterly basis. So any claims that inappropriately use the EPA may result in a mass adjustment. So, and payment for those claims will be taken back. So if that does happen, claims that use the EPA inappropriately will have to rebill those claims without that EPA. And I apologize, that was a lot. So please reach out if you have any questions. And we are at time. So thank you so much, everyone.